Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Second Allograft for Hematologic Relapse of Acute Leukemia after First Allogeneic Stem Cell Transplant from Related and Unrelated Donors, the Role of Donor Change, by Maximilian Christopiet and co-workers. My name is Richard Champlin, and I am Chairman, Department of Stem Cell Transplant and Cellular Therapy at the University of Texas MD Anderson Cancer Center in Houston, Texas. The oncologic specialty is hematology, medical oncology, and hematopoietic transplantation. Disease recurrence is a devastating event after allogeneic hematopoietic stem cell transplantation as treatment for acute myeloid leukemia. The median time to relapse is approximately 4 months post-transplant, and the majority of relapses occur within 2 years. The prognosis is usually poor. Overall 5-year survival of all patients relapsing post-transplant is about 5%. However, many patients can respond to further treatment, and a substantial minority can still achieve a durable remission, usually after a second allogeneic transplant or a donor lymphocyte infusion. Relapse generally results from residual malignant cells that survive the preparative regimen and are not eliminated by the graft versus leukemia effect, referred to as GVL. In a minority of patients, relapse appears to occur in donor-derived cells. Relapse may occur by an immune escape mechanism from the graft versus leukemia immunologic effect. This may be due to loss of expression of leukemia-related antigens. One case was reported associated with loss of expression of an HLA haplotype by deletion of chromosome 6. Another mechanism of immune escape is development of tolerance in donor-derived T cells. A number of patient, disease, and treatment-related factors identify patients at highest risk for relapse post-transplant. The major disease-related factors predicting for relapse include disease status, that is, active disease versus being in remission at time of transplant, cytogenetics, and high-risk molecular abnormalities, such as the FLT3 internal tandem duplication mutation. The cytogenetic abnormalities associated with relapse post-transplant differ from those reported with standard chemotherapy. Only the presence of complex cytogenetics with 4 or more abnormalities is predictive of relapse in a large CIBMTR registry analysis. Donor factors may affect the risk of leukemia relapse. Use of donors with predicted NK cell alloreactivity or expressing certain activating KIR genes or KIR haplotypes relate to natural killer cell reactivity, and these may be associated with a reduced risk of relapse. Non-myeloablative and reduced intensity preparative regimens are commonly used to allow treatment of older and medically infirm patients who might not be able to tolerate a myeloablative regimen. This approach is associated with a higher risk of relapse, but this is counterbalanced by lower treatment-related mortality. The presence of pre-transplant or post-transplant minimal residual disease is associated with an increased risk of leukemia relapse post-transplant. Chimerism analysis post-transplant has been reported to predict leukemia relapse, but data is conflicting. Loss of donor chimerism or persistent mixed donor-recipient chimerism may precede acute leukemia relapse. Mixed myeloid chimerism, particularly with an increasing proportion of host myeloid cells, has been associated with leukemia relapse Patients relapsing post-allogeneic hematopoietic transplant have a poor prognosis. The duration of remission after an allogeneic transplant is an important predictor of survival after recurrence. The best results occur in patients with a remission duration greater than 6 months. In our experience, 1-year survival was 8 versus 30% for patients with relapse less than or greater than 6 months. Reported adverse prognostic factors include receiving the initial transplant while in relapse, having poor cytogenetic or molecular markers of disease, and receiving transplants from alternative donors. Recipient age, performance status, comorbidities, and presence of active graft versus host disease are important factors in choosing salvage treatments. Indolent relapses are more amenable to interventions than rapidly proliferating leukemias. Patient preference is an important consideration. Transplant patients have already gone through a prolonged active treatment, often at a remote transplant center. Some patients are inclined to continue aggressive therapy, while others realistically prefer to return to their homes and receive palliative care. Despite anecdotal reports of success, withdrawal of immunosuppressive therapy is unlikely to induce a clinical benefit in acute myeloid leukemia patients with morphologic relapse and should not delay more effective interventions. Graft versus host disease often complicates early or rapid withdrawal of immunosuppressive therapy and may jeopardize success of subsequent treatment. The worst situation is to have relapse and acute graft versus host disease. We recommend continuing immunosuppressive therapy in patients who have active graft versus host disease and a slow taper of immunosuppressive treatment in others. Results of conventional chemotherapy remain poor in patients relapsing post-transplant. The reported CR rate ranges from 0 to 60% and is highly influenced by the remission duration and patient selection factors. Patients may respond to salvage chemotherapy, particularly if they had chemosensitive disease before the initial transplant. In that case, retreatment with an anthracycline and cytarabine-based therapy may be effective. Patients with FLT3 ITD mutations may benefit by treatment with an FLT3 tyrosine kinase inhibitor. 5-azacitidine has been used for treatment of patients with minimal residual disease or overt relapse following a stem cell transplant. It is a DNA hypomethylating agent that can induce leukemia cell differentiation and may also increase the immunogenicity of tumor cells, augmenting graft versus leukemia activity. In several small studies, about half of patients with minimal residual disease or low bulk relapses have achieved remissions. Chemotherapy alone generally produces only short-term responses in patients relapsing post-transplant. The best results have been achieved when a DLI or a second allogeneic transplant is performed to consolidate a chemotherapy-induced response. DLI, or donor lymphocyte infusions, are frequently given to augment graft versus leukemia as treatment of relapse post-transplant. Although highly effective for treatment of CML, acute myeloid leukemia has only intermediate sensitivity to GVL effects. Donor lymphocyte infusions are generally ineffective for relapsed disease when given alone, although there are some long-term survivors when given following salvage chemotherapy. Results are very dependent on patient selection. Donor lymphocyte infusions may be complicated by graft versus host disease, infection, and pancytopenia. Most responses do not translate into long-term survival. Schmid and coworkers reviewed 399 patients with acute myeloid leukemia relapsing post-transplant. Their estimated survival at 2 years was 21% for patients receiving donor lymphocyte infusion and 9% for others. Better outcomes were associated with age less than 37 years, relapse occurring more than 5 months post-transplant, and the use of donor lymphocyte infusion. A lower tumor burden at relapse, female sex, favorable cytogenetics, and being in remission at the time of DLI were predictive for survival in multivariate analysis. 2-year survival was 56% if DLI was performed in remission or with a favorable karyotype, and 15% if DLI was given in the period of aplasia or patients with active disease. A number of strategies have been studied to improve the efficacy and reduce DLI-induced graft versus host disease. Adoptive transfer of ex vivo selected T cells, recognizing minor histocompatibility antigens, may avoid the risk of graft versus host disease while mediating an anti-leukemia effect. Warren et al. Reported the results of a phase 1 clinical trial in which the safety of adoptively transferred donor-derived CD8 cytotoxic T cells was evaluated. T cell clones recognizing minor antigens expressed by recipient hematopoietic cells, but not by recipient dermal fibroblasts, were given to patients with recurrent acute myeloid leukemia after a myeloablative allogeneic hematopoietic transplant. Generating the therapeutic doses of T cells was complex but feasible. Unfortunately, graft versus host disease with pulmonary toxicity was seen in 3 of 7 patients, and the authors were unable to show sustained in vivo persistence of the transferred CD8 positive cells. Next generation sequencing may be able to identify target genes for immunotherapy for each donor-recipient pair, and this general approach needs to be pursued. Second, hematopoietic transplants can induce durable complete remissions in a fraction of AML patients with relapse post-transplant. Registry data and single-center retrospective analyses show the likelihood of success with a second transplant is increased by achievement of a morphologic complete remission or minimal disease state prior to the second transplant, as well as by a complete remission duration greater than 6 months after the initial allogeneic transplant. 20 to 30% of patients can achieve long-term disease-free survival in this setting. We believe that this is the most effective treatment for patients in good medical condition with a chemosensitive relapse, and a second allogeneic transplant should be considered as the standard of care for these selected patients. At the MD Anderson Cancer Center, we have observed that patients who achieved a complete remission or a complete remission with incomplete hematopoietic recovery after salvage chemotherapy had a 21% long-term survival following a second hematopoietic transplant. Selected patients with low bulk residual disease or untreated early relapse may also benefit from a second transplant. 16% of these patients survived disease-free for 5 years. Patients with overt relapse or chemo-resistant disease are not good candidates for second transplants and should be offered supportive care or considered for clinical trial of novel therapeutic approaches. There is no consensus regarding the optimal preparative regimen for a second allogeneic transplant. Myeloablative and reduced intensity regimens have been used. Myeloablative regimens produce lower relapse rates, but the treatment-related morbidity and mortality is higher than with reduced intensity conditioning. Most centers use a different regimen than with the initial transplant, and reduced intensity regimens have generally been used in older patients. At our center, if a busulfan-based regimen was used for the initial preparative regimen, we generally employ a reduced intensity melphalan and fludarabine regimen for the second transplant. For young, fit patients, a high-dose total body radiation-based regimen may be considered. Since much of the benefit of allogeneic hematopoietic transplant is related to the immune graft versus leukemia effect, there has been speculation that use of a different donor might improve the outcome of the second transplant. This concept was tested in a study by Christo Piet et al. On behalf of the German Registry for Stem Cell Transplantation. They examined the results of second transplants for patients with relapsed acute leukemia, comparing the results using the same or an alternate donor. They could not demonstrate an advantage for using a different donor for the second transplant. Second transplants from a related donor had a better outcome than those from an unrelated donor. In conclusion, relapse of acute myeloid leukemia following an allogeneic hematopoietic transplant is a nominous event with generally a poor prognosis. Selected patients may respond to additional salvage chemotherapy. Approximately 20% who respond to further therapy can achieve long-term remissions with a second allogeneic transplant or with intensive chemotherapy followed by a donor lymphocyte infusion, particularly those who've had a prolonged disease-free interval after the first transplant. there is no apparent advantage in selecting a different donor for the second transplant. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.